This is Advanced Directives for the Geriatric Trauma Patient, created by Group 5 for Nursing 321, Gerontological Nursing and End-of-Life Care. Falls and motor vehicle accidents are the two most common causes of traumatic injury in the older adult. The elderly are also prone to higher mortality rates related to pre-existing comorbidities. These patients can't always make up their own decisions after a traumatic injury. This could leave those decisions up to the family or even the trauma team. An advanced directive could help tremendously in these situations by helping us as healthcare workers to honor the patient's wishes. This review of literature assesses the need for advanced directives in elderly trauma patients and was completed using peer-reviewed articles from multiple online journal databases. Geriatric trauma statistics. Accidents including falls, motor vehicle accidents, and poisonings are the number 8 cause of death in the elderly. And 20% of traumas are adults over the age of 65. This number actually increases annually as the population ages. A German study conducted by Grau and Bouchard showed that less than 13% of adults in their emergency department had completed an advanced directive before admission. So, the geriatric trauma patient, what do they look like? They are more likely to be injured. They differ significantly from their younger trauma patient in physiology, shock response, and mechanisms and types of injury. We know that geriatric patients can present differently from their younger counterparts when we're looking at presentation, and trauma is no different. These patients over the age of 65 are also associated with worse patient outcomes, and that includes an increased risk for mortality. Advanced directives. So an advanced directive is a legal document that expresses the wishes of a person if they are no longer capable of making their own decisions. This helps the family, friends, and even the care team understand what the patient wants when they are no longer able to say it themselves. From the National Institute on Aging, research shows that advanced directives can make a difference and that people who document their preferences in this way are more likely to get the care that they prefer at the end of life than people who do not. The types of advanced directives are a living will, a durable healthcare power of attorney, POLST, or physician's orders for life-sustaining treatment, and MOLST, the medical orders for life-sustaining treatment forms, a DNR form, and organ donation forms. What is the importance of an advanced directive? Hill says it best when we are looking at the importance of advanced directives. The quote is, "Trauma occurs unexpectedly and often involves otherwise healthy individuals who may not have felt the need to complete an advanced directive. Trauma frequently occurs at a distance from one's hometown. Trauma patients are often admitted to a distant regional trauma center in which they have never been treated before. There may be no familiar provider and no established medical record available for review. Family members are often not present or are also injured and therefore unavailable for advice regarding difficult care decisions. Presence of an advanced directive allows patient wishes to be known, which can make respectful treatment decisions easier when the patient and family are unable to participate." So then we ask ourselves, why are advanced directives needed? There are a lot of situations that the elderly may find themselves in where they're not able to express their needs or concerns. Life-threatening illness is a major concern. If a patient is too ill or codes before they let us know what they want to happen, then we have to go with what our protocols and policies say. Another is compassionate care at the end of life. Hill states, "There has been an increasing emphasis on the role of advanced directives in providing high-quality, economic, and compassionate care to patients at the end of life." And The Patient Self-Determination Act of 1990 required healthcare systems to provide patients with information about their right to make advance directives. The geriatric patient may know that they're dying and wish to do so peacefully, while the family, who is making the decisions, decides to continue aggressive treatments. An advance directive could prevent that situation. And finally, unexpected accidents. As stated earlier, accidents are the number 8 reason for death in the elderly. We know what an advance directive is, why it's important, and why it's necessary. So how do we as nurses honor the geriatric patient's decisions? If trauma occurs, we should be looking for an advance directive, either in the chart or on the person. The family is generally not available, as we stated before, to provide paperwork and answer questions. So we have to work quickly to find out if there's an advance directive in place or not. If, in the case one is not available, frailty scores can show us a lot about the geriatric trauma patient. By assessing their frailty score, this can help the trauma team make an ethical decision in what would be the best for the geriatric trauma patient. How do we medically treat a geriatric trauma patient without an advance directive? What is the next ethical step in the geriatric trauma patient who doesn't have an advance directive or family to advocate for them? This is a sticky situation, and a frailty score can tell you a lot about the patient. Mortality rates are high in elderly trauma patients, so we need to know about frailty and about the injuries as well. This study identified that the mortality rates at 1 year post-injury remained above 40%. This is an insane number to think about. First, let's look at frailty in older adults. Frailty can be defined as either a state of reduced physiological reserve and associated with an increased susceptibility to poor healthcare outcomes, or a state of vulnerability or poor resolution of homeostasis after a stressor event and as a consequence of cumulative decline in many physiological systems during a lifetime. Now, we are looking at vulnerable individuals, patients with multiple geriatric syndromes. Frailty can cause immunologic impairment and issues with the endocrine, skeletal, and neurosystems. Frailty directly affects outcomes on these patients, and there is an increased mortality rate, increased accidents, and decreased quality of life for them. Well, how do we score frailty? There are dozens, if not hundreds, of frailty screening tools out there, but we as medical professionals have yet to decide which is the best. These scoring systems are shown to lead to better assessments and even improved discharge planning. Here we have a few of the frailty screening scales. The first is the Edmonton Frail Scale, or EFS, which is comprised of 10 questions and 1 physical assessment, the timed up and go. Scores range from 0, not frail, to 18, very frail. Scores of 8 and above are defined as frail. The FRAIL, or Frail Scale, is self-reported and includes questions about fatigue, resistance, ambulation, illnesses, and loss of weight. The score on this tool's range is non-frail to frail. The frailty phenotype asks about weight loss, measured weakness, self-reported exhaustion, measured slowness, and low activity. Scores are frail, intermediate, and robust, or not frail. The timed up and go test measures functional mobility. The patient starts in a seated position, performs a 10-foot walk, and then returns to the chair. Anything over 10 seconds is considered frail. Lastly, we have the PRISMA questionnaire, a self-reported questionnaire about age, sex, health problems that require a limit on activities, help needed regularly, health problems that require one to stay at home, having someone to count on if you need them, and regular use of assistive devices for walking. Answering yes to 3 or more of the 7 questions on this questionnaire means potential frailty. Now, when we are assessing the elderly trauma patient, not all of these tools will be appropriate for our situations. In these cases, nursing judgment is used. On the topic of scores, we have the Injury Severity Score, ISS, and the Revised Trauma Score, RTS. When I said that we should be looking at injuries, this is how we do that. These scoring systems really help us assess the elderly trauma patient and can guide our care. With more severe trauma, patients are less likely to be able to verbalize their wishes. ISS assessments are only used in patients with multiple injuries. ISS scores from 0 to 75 and mild to profound. Over 15 is considered major trauma. The downside of the ISS is that the assessment is only scoring one injury, the worst injury, for each region of the body. The RTS has been shown to accurately predict death and is scored based on the first Glasgow and the first set of vital signs. A score of less than 4 means that the patient should be treated in a trauma center. Patient education. What are we teaching them? We need to be educating our patients not only on the basics of advanced directives, but what's to do with them once they are completed. When we are completing admission histories, we ask the patient if they have an advanced directive. Many times, a patient will tell you that they have one, but they don't have it with them. Other than asking the family to bring in a copy, inform the patient that they should provide their primary care doctor with a copy to put into their chart, and that they could also carry this card in their pocket if a copy of their advanced directive is not on file in the event of a traumatic accident. This will notify the healthcare team immediately that the patient has advanced directives. Accessing medical records outside of a hospital system is tough and definitely not a task easily done in an emergency. Patients also don't typically carry around or travel with a full copy of their advanced directives, so wallet cards are a great option for them. Without advanced directives, families and providers may inaccurately assume end-of-life wishes. Once the patient completes the advanced directive, we need to educate them to speak with their family about their wishes and to place a copy somewhere safe and let their family members know where it is. To summarize, advanced directives are legal documents that help a patient express their wishes when they are no longer able to do so. Only about 13% of adults were found to have an advanced directive in triage at one emergency room. Advanced directives should be filled out before an accident occurs. Copies of advanced directives should be kept in the chart and with the patient if possible. Frailty and injury assessment play a role in assessing the elderly trauma patient completely, and education is imperative to getting these advanced directives completed by our elderly patients. Thank you.